Good evening, everybody. First of all, I thank Walter Bushner for giving me this opportunity of being a part of this scientific session. My wishes to all the chairpersons and people of the dais also. The topic given to me is liposomal iron. Is it going to be a game changer in obstetric practice? So anemia, all of us know, it's the commonest medical condition that we come across in any pregnant woman, and it is defined as the presence of decreased RBCs whereby the oxygen carrying capacity of the woman is reduced. So if you look into the global prevalence of anemia, India has got a 53% of women who are suffering from anemia, and that is going to lead to the highest maternal mortality, morbidity, low birth weight, and high infant mortality. So there are around the Global Nutrition Report in 2016 says India ranked 170th in terms of anemia prevalence, whereas US ranks #1. That is only 11.9%, and I came to know that Australia even it is lesser than that, and India has got an incidence of 48%. The prevalence of anemia is quite common in various groups, like starting from children, adolescent girls, pregnant women, non-pregnant women, and in the perimenopause, also breastfeeding women, etc. Only the adolescent boys, they escape, but still they have 1/3 of them, they have anemia. Who are prone? Any woman, infants, children, the people who are on vegetarian diet, and frequent blood donors. So when you consider the Indian perspective, 41%, that is 56 million pregnant women are affected mainly by iron deficiency, and it leads to 40% of the maternal death, either directly or indirectly. And 3 times higher incidence of iron deficiency anemia is seen in India rather than in other countries. All of us know about the ICMR classification based upon the hemoglobin level. When it is less than 4, it is very severe. 4 to 6.9, it is severe, and 7.99, it is moderate, and mild when it is 10 to 10.9. Rather, a pregnant woman should have a hemoglobin level of more than 11 grams in the first and in the third trimester, and in the mid trimester, it should be beyond 10.5. The types of anemia, the commonest is iron deficiency anemia, where the RBCs are microcytic, microchromic, hypochromic, and they have poikilocytosis and anisocytosis. Other types of anemia are megaloblastic anemia, where it is mainly because of the reduction in the folic acid and B12. The size of the RBCs become larger. They are called macrocytes, and they have impaired DNA synthesis to a lesser extent, and to a lesser extent RNA and protein synthesis. Other type of anemias are pernicious anemias, where it is because of B12 deficiency due to lack of intrinsic factor, and aplastic anemia, where the bone marrow fails to produce. So when you look into the process of erythropoiesis, whenever there is hypoxia because of low RBC mass, what it does is it stimulates the kidneys to produce what is called as erythropoietin, which acts upon the bone marrow to increase the erythropoiesis, and finally it copes up. But for the erythropoiesis to happen, we need 2 important things. One is 1/2 of erythropoiesis, that is up to 21 days of erythropoiesis, it is erythropoietin dependent, and the latter half, that is around 10 to 15 days, it is based upon the requirement of iron. So it starts up to pro-erythroblast, it is erythropoietin dependent, and beyond that, erythroblast, reticulocytes, and RBCs, it is iron dependent. So in an iron cycle, we need daily 20 to 25 milligram of iron is needed, but what we take in the food is only 1 milligram per day, and the rest comes from what the old, that is senescent RBCs are being trapped by the macrophages, and there is recirculation of the iron. So the most important symptoms of iron are fatigability, that is the first sign, dizziness, pale skin, lips, nails, cold hands and feet, and there is shortness of breath, and fast and irregular heartbeat, and cognitive problems are there. It affects the entire body, starting from brain, heart, spleen, skin, muscle, digestive tract, and respiratory tract. Why do anemia happens in pregnancy. It is basically in India, it is nutritional iron deficiency. So the women start their pregnancy with a negative balance, that is poor pre-pregnancy iron level, iron, folic acid and B12 deficiency, and chronic blood loss due to parasitic infection, multiparity, multiple pregnancy, short intervals between the pregnancies, recurrent urinary tract infections, and rarely hemolytic anemia, what we see in the pregnancy-induced hypertension or hemoglobinopathies. So as a result of anemia, the mother is affected. There is poor work capacity, performance, and disturbances of postpartum cognition and emotion. Fetus has got iron deficiency again, born with iron deficiency and IUGR, and pregnancy outcomes, the woman can have preterm labor, low birth weight, placental abruption, and peripartum blood loss can be more. And the infants have got a high risk of iron deficiency and cognitive development is abnormal. So the commonly used iron salts for treatment of iron deficiency anemia is, you can give it only either a ferric salt or a ferrous salt in mild to moderate cases only. Severe cases, it is not, oral iron is not going to help because it takes quite a longer time to improve the hemoglobin. So these are all the various conventional iron preparations that are available from ferrous salts up to IPC or carbonyl iron. The recommendation by ICMR is the pregnant woman should have 35 milligram of iron and 300 micrograms of folic acid. But whereas the WHO recommends 30 to 60 milligram of elemental iron has to be supplemented along with 400 micrograms of folic acid, probably starting from early second trimester. Probably in the first trimester, woman may not tolerate because of vomiting. So the other factors of oral iron absorption depends upon the dose, status of the iron storage of the patient, how it is being administered, stability of the gastric acids, elemental iron, and bioavailability. So always when you take a oral iron, it has to have a basic carrier protein, that is divalent metal transporter. Without that, the iron cannot be transported into the gut or from the gut into the blood. So there is limitation of iron absorption whenever there is problems with this DM, that is divalent metal transport protein, and it can have some some of the adverse effects. So how iron absorption is regulated? See, too much of iron, what happens? Binding iron capacity of transferrin is exceeded. It gets deposited in the tissues, free radical damage occurs, and organ damage can happen. And what happens if there is too little iron? There is cellular dysfunction and anemia, and hence it has to be regulated by what is called as hepcidin. Hepcidin, suppose, what happens in hepcidin is, it's a substance that is produced by the liver, where it is increased in refractory iron deficiency anemia, anemia of inflammation, and chronic disorders. And the hereditary hemocytochromatosis and iron overloading and toxicity can happen in whenever there is excess iron. So there was an article in a paper where there is a new invention of some iron regulating hormone that is called as erythroferron. So what does erythroferron does? It is a protein hormone produced by the erythroblast and inhibits the action of hepcidin. Because what happens is, when hepcidin becomes more and more, as in response to low hemoglobin level, it will suppress again the intake of absorption of iron. So some of the studies say that if you are going to give alternate days of iron therapy, it will give the same value because that may not alter the hepcidin level. So the erythroferron is a hormone. What it does is, it inhibits iron transport, that is, it suppresses the hepcidin. So thereby promoting the iron absorption from the gut and release from the stores. The limitations of the conventional iron are poor bioavailability because it needs that DM, that is divalent metal transporter. And again, only a minor portion of whatever iron, oral iron we give is being absorbed, that is less than 10 to 20%. And even that it depends upon the bioavailability. Again, gastric intolerance is quite high. 30 to 70% of the patients who are on routine conventional iron preparations, they do not tolerate because of vomiting, gastric problems, as well as most of the iron is being excreted in the gut. Higher the intake of iron, more are going to be the side effect. So again, this is what is the non-compliance. And most of our women say that is up to 25 to 75% of the women are non-compliant about the routine oral iron. And the treatment options that are available currently for IDA or oral iron therapy, parenteral and blood transfusion. Oral iron therapy, it is very clear that it is only can be given for a mild or moderate cases. But parenteral iron can be given to women who do not tolerate the oral iron, or when they have undergone gastrectomy or gastrojejunostomy, bariatric surgery, and other small bowel surgeries. So this is for the normal conventional iron to get absorbed. Acidity is needed. It gets absorbed in the duodenum or in the proximal jejunum, and integrity can be compromised. That is, integrity of the gastric mucosa can be compromised by several conditions, which will lead to malabsorption, and maximum of 1 to 2 milligram of iron is being absorbed per day. So when you go higher with the iron dose, there are higher the GI side effects. So the limitation of the conventional iron is it can produce GI side effects, what I have mentioned earlier, and our Indian women are more bothered about the black color stools, and they have a myth saying that if they take oral iron, the babies are born dark, and there is poor absorption as it interferes with the phytates, tannins, and that are present in the food, and non-compliance and the slow improvement of the hemoglobin level. So we need to choose a smart iron. What is that smart iron? This should have an unique pharmaceutical, excellent GI tolerance, and a higher bioavailability, which should be orally absorbed. Bypassing the gastric mucosa, it should enter into the lymphatic system and then straight into the bloodstream, and it should be, hepcidin should be bypassed. So what is that newer iron that is being available? That is the liposomal iron that can be used, and the lot of literature evidence to say that it can improve the oral tolerance is there. What is liposomal iron? It is a micronized, highly bioavailable form of encapsulated iron that has been formulated in the beginning at Japan, and again because of the microsomal technology, it has got lowered side effect. It is stable in so many conditions, not dependent upon the phytates and the acid level of the gastric mucosa, and there is no free iron that is being released, so there is no side effects and free radical release is not there. So what happens is, in the molecule here is the ferric pyrophosphate that is micronized, and that again is being micro encapsulated by the liposomal bilayer, which is a physiological one. So this passes through the stomach undamaged, then reaches the intestinal lumen, and from the intestinal lumen it gets adherent to the intestinal mucosa and straight that is being absorbed. So it doesn't need the divalent metalloprotein, but it has got the advantage of coming direct contact with that of the intestinal mucosa. It is being absorbed by the process of what is called as endocytosis or pinocytosis by the M cells and the intestinal mucosa. Then it straight reaches the lymphatic. From the lymphatics, it goes to the liver. So the liposomal encapsulated iron fuses to the cell membrane and enabling the direct release of iron into the interior of the cells. So this differs from other preparation in respect to the technology, because the conventional iron is not micronized or microcapsulated. It has got no target delivery and it has got oxidation of iron, but whereas liposomal iron has got no oxidation, it has got a target delivery. It doesn't chelate with the other metals like similar to conventional one. Absorption is not dependent on divalent metalloprotein, and bioavailability is good in liposomal one. Gastric side effects, metallic taste are not found with the liposomal iron. So it has got this, even at the ferric pyrophosphate, the liposomal iron was 2.7 times or 3.5 times more bioavailable than ferric sulfate. So it is outsmarting the hepcidin. It is a smart iron packaged and delivered differently. And in a study by 60 gynecologists in patients suffering from IDA, there was a rise in the level of hemoglobin from baseline within 2 months up to almost 2 gram percentage of iron is being elevated. So it is effective both therapeutically as well as prophylactically. Again, in a women with non-pregnant women with iron deficiency anemia, one more study says the same thing. By the end of 12 weeks, the rise in the hemoglobin can be approximately to 2 grams percentage. So this was another Mexican study where they have just fortified the food rice with ferric pyrophosphate. That is also found to prevent the anemia incidence. It is reduced by around 80%. So the safety and efficacy in pregnancy is what is needed. and variant formulations, that is ferrous iron 30 milligram, sucrosomal iron 14 and 28 milligram. When you consider this 14, there is iron, liposomal iron of 28 milligram per day shows the higher hemoglobin rise and ferritin levels at 28 weeks in the postpartum period. So it has got definitely a better safety profile as far as the gastric symptoms are considered. And after 8 weeks, the gastric symptom sign score has been reduced to 1.46. So it has got, again, apart from the gastric side effects, there are no other, like it doesn't have a free oxygen radical release is not there, and all the other advantages over the conventional iron are seen. So when you look into the compliance, among 1,073 subjects who were interviewed, they found that 98% of the patients, they had a good acceptability to liposomal iron. So apart from that, US Food, Drug and Administration as well as European Food Safety Authority have defined that ferric pyrophosphate can be used safely as a food addictive. So that is one more advantage. So let us see what the guideline says. The guideline, that is according to FIGO, minimum dose of 30 milligram of elemental iron is needed. ACOG and UK guidelines, they say that sustained release or entry-coated preparations are not that much effective. WHO says that 30 to 60 milligram of elemental iron and 400 micrograms of folic acid is recommended to prevent maternal anemia for pregnant women. So why liposomal iron is going to be a game changer is because of the advanced technology of micronization. It has got the capacity to being absorbed easily, 4 times higher bioavailability, faster hemoglobin rise, 1.7 grams per deciliter in 30 days, and with no GI side effects, and it is being strongly recommended by the WHO. So I think to reach anemia-free world and anemia mukt Bharat, this liposomal iron is going to be a game changer today. And once again, I thank you for the opportunity given. Thank you.